All right, everyone, I think we're going to go ahead and get started. My name's Shauna Newton. I'm one of the Chief Cardiology Fellows, and I am going to be presenting 3 patient cases for our semi-annual Clinicopathological Correlates Conference. I'm going to be joined by Dr. Kelly Smith. He is an anatomic pathologist, a professor here at the University of Washington, and an expert in renal and cardiovascular pathology. He is joining us online. And we'll just go ahead and get started. So disclosures, we have no financial disclosures for today's presentation. I will just say a couple just of my own personal disclosures is that all cases presented are based on real patients and may sound familiar. There could be some patients that you have taken care of before, but details may have been modified, and this is just for clarity, flow, or educational purposes. So our learning objectives today are to recognize the utility of endomyocardial or vessel biopsy in pathology when there is diagnostic equipoise, identify pathological and histological features of the presented cardiovascular disorders, correlate a patient's clinical course with the underlying pathology. We have 3 separate cases today. We'll be discussing a non-ischemic cardiomyopathy, a case of dilated aorta, and a diffuse vasculopathy. So we'll start with the non-ischemic cardiomyopathy case. So we have a 59-year-old woman who presents with epigastric abdominal pain, nausea, and vomiting after a trip to Mexico. She describes fevers, chills, and pain in her bones. She has no chest pain, shortness of breath, or edema. Her past medical history is pretty unremarkable, just some prediabetes and hyperlipidemia. She's not on any medications. Family history is non-contributory, and social history, she has no tobacco, alcohol, or drug use. She initially presented to an outside hospital, and here's her vital signs. We can see that she's mildly hypotensive. She has a heart rate of 121, and then she was febrile upon presentation. Her temperature was 39 degrees Celsius. On exam, she was ill-appearing, laying on her side, and then she was just tachycardic, but otherwise didn't really have any prominent cardiovascular findings. But she was noted to have some diffuse mosquito bites on her skin. Looking at her labs, her BMP is notable for just a low bicarbonate level. Her CBC was notable for thrombocytopenia. She initially had a platelet count of 124, and this nadired to 68. She also was described to have lymphopenia and normal eosinophil count. Her BMP is 354, and her troponin was initially 0.23. Over the course of a couple of days, it went up to 6.69. She had mildly elevated liver function tests and a lactate of 4.6. Her ESR and CRP within normal limits, and then viral testing is pending. She has this EKG here, and I think what's notable to me is, she has sinus tachycardia, and low voltages, and we do see some subtle diffuse ST segment elevation and PR depression. She didn't have any arrhythmias when she initially presented. For echocardiogram, we can see that she has this moderate-sized pericardial effusion. Her EF was low, estimated to be 25 to 30%, and then she had pretty prominent segmental wall motion abnormalities. It was just noted that the apical cap and basolateral walls have the best motion. Her RV was normal size with mildly reduced function, and she was noted to have thickened walls measuring 1.6 centimeters circumferentially. She has no priors for comparison. So what happened at the outside hospital? She gets a coronary angiogram, which showed diffuse luminal irregularities and non-obstructive coronary artery disease. Her right heart cath numbers are here. We can see that she has elevated biventricular filling pressures, and her cardiac index is low at 1.4. There was a comment in the outside hospital report that she has equalization of diastolic pressures and mean pressures in all 4 chambers, suggesting a restrictive cardiomyopathy. Just one caution when interpreting these values, this patient also had a moderate-sized pericardial effusion, so we should be considering different diagnoses as well. So she ends up getting transferred to University of Washington. She gets a CT chest out on pelvis, just notable for some bilateral pleural effusions. And then she gets a pericardiocentesis and balloon pump placement, and she has immediate improvement of her filling pressures, pretty much everything normalized. Unfortunately, over the next couple of days, she still had to be on a balloon pump and on dobutamine. And then actually, she required a lot of IVF resuscitation. She had persistent hypotension and actually low filling pressures. And so, in summary, we have a 59-year-old woman with no relevant past medical history who presents with GI distress, found to have a new non-ischemic cardiomyopathy, pericardial effusion, and a mixed cardiogenic distributive shock after a recent vacation to Mexico. And so, her next step in management, due to diagnostic uncertainty, the patient undergoes endomyocardial biopsy. But before we show the biopsy results, what do you all think is the etiology of this patient's cardiomyopathy? We do have a Zoom poll that we're going to try out where you can submit your answers to this question. And I'll just allow the people in the room to either talk with your partner or you can also participate in the poll. So I'll just give that a few seconds.
Maybe we should have a discussion. How about we wait? Yeah. Before you showed the ESR and CRP, I was thinking of myocarditis, but I guess I'm not sure. I'm curious what other people think.
Well,
quite frankly, and I'm not so impressed with abnormal, quite frankly. I don't put a whole lot of stock in it personally.
I can tell you what our Zoom poll results are. We have 40% that think this is 45% that think this is a viral myocarditis, 25% think this is Chagas cardiomyopathy, 8% genetic cardiomyopathy, 12% giant cell myocarditis, and 8% an acute viral illness. So pretty diffuse results. She just got back a week ago, pretty recently. Okay. So next, let's find out what happened here. So Dr. Smith, if you want to go through the pathology results, and I'll advance the slides here.
Thank you, Shauna. I hope everyone can hear me.
Larry here. Yeah, I didn't.
I'll use the microphone. Wrong again.
Okay, are we ready?
I don't know if Dr. Smith.
Can you
Sorry,
hear
everyone. Dr. Smith is attending remotely. We're just trying to get him to be able to talk on the Zoom here.
Hello, can you hear me? I'm lighting up on my end.
Yeah, mine is all the way up.
I think people on the Zoom can hear me. It might be the speakers in the room. Is that possible?
I've turned it on onto my laptop so we can hear you in the room.
Okay, excellent. I'll try to talk as loud as I can. So thank you, Shauna. So I think that the endomyocardial biopsy here is notable for a lot of what it doesn't show. So it doesn't show most of those diagnoses. We see a piece of myocardium. There are about 4 generous pieces of myocardium, and there's no significant inflammation. And so there's no myocarditis, no giant cell myocarditis, or any other type of inflammatory disorder. And we can go to the next slide. And basically, if we look at higher power, there's very, very subtle changes. And you can see at the larger or the higher magnification photomicrograph on the right that there's some very subtle vacuolization in the cardiomyocytes. And we'll look at that at higher power in the next slide. And so here's a couple of higher power images, and you can see then these clear little tiny vacuoles and spaces in the cardiomyocytes. And this is what we term fatty degeneration. and you can advance it one more. I think a pop-up comes. Yeah. So these clear droplets that we're seeing are really lipid droplets, and this is thought to result from a disturbance in mitochondrial function or oxygen-dependent lipid metabolism. So it's a non-specific finding that we can see and can be associated with a number of different types of etiologies. And I think, with the biopsy here, then we're left with this dilemma. Are we seeing changes in the heart that are telling us that it's not functioning well? And is that due to myocarditis elsewhere that we just haven't sampled? Or is there some other type of injury that's causing this, that's not really due to essentially an attack by lymphocytes and other types of immune cells on the myocardium itself? Thanks.
Thank you so much, Dr. Smith. So the final diagnosis, it was dengue myopericarditis. She tested positive for both dengue virus IgM and IgG antibodies, but I will say that this diagnosis was pretty debated, even between like different providers that were taking care of her. Some of them would call this myocarditis, and actually some of them, they just thought that this was more of a stress cardiomyopathy because of the acute viral illness. So kind of unclear. I wanted to just have a few words about dengue because I hadn't known much about it before this case. And so dengue is a vector-borne virus. It's caused by the Aedes aegypti mosquito, and it's found in the regions above. Those are the regions in like that purplish color. There are 4 different RNA viruses that can cause dengue. An infection with one of these viruses confirms long-term immunity to that specific virus, but only short-lived protection against other dengue viruses. So you can actually get dengue multiple times. You could get, I guess, up to 4 times if you get all 4 viruses. And then the risk for severe disease is actually greater during your second dengue virus infection. Interestingly enough, there's actually a dengue outbreak in the United States. So last year had the highest recorded cases of dengue ever of 3,316. And there's been 331 documented US cases so far. Most of these cases are brought back by travelers, but there has been over 75 cases of local spread in Texas, Arizona, Florida, and California. This is where the mosquito could very likely live in the United States. So it might be something that we could be seeing more frequently. How does dengue present? So it's usually a viral syndrome. Symptoms develop within 4 to 7 days of a mosquito bite, and it's characterized by the following symptoms that you can see in the picture there. Typically, patients describe fevers, headaches, and then usually bone pain is like the classic syndrome. It was previously called break bone fever. Labs generally demonstrate thrombocytopenia and leukopenia. In less than 5% of patients, you can get severe dengue, which is also called hemorrhagic fever. And this is characterized by increased vascular permeability. So you have pleural effusions, ascites, pericardial effusions have also been described. And you can get bleeding manifestations, including petechiae, ecchymoses, purpura, and GI bleeding. These patients also can develop shock. Usually it's more of a distributive shock picture. Treatment is supportive care. And we do have a vaccine available called Denvaxia, but it's only improved in the US for children aged 9 to 16 with laboratory confirmed previous dengue infection who are living in areas where dengue is endemic. So not a lot of patients that we'll be seeing for this. And the reason being is it's only 60 to 80% effective, and you have a higher risk of severe disease during your second case of dengue. And so if we give you a vaccine and then you develop dengue and you haven't had it before, you could have a higher risk of severe disease. So myocarditis can happen in dengue. There have been documented cases with histopathological features that are more consistent with lymphocytic myocarditis, which is, I think, what we commonly see with viral myocarditis. And the prevalence was all over the place. There's this one large meta-analysis of 16 articles, which described a prevalence of 2.4 to 78%. And I think that this is mainly driven by the way that people diagnose myocarditis. In several of the papers, it was just based on elevated troponin and EKG findings. And so I think there's probably just a lot of myocardial injury with patients with dengue, but not necessarily myocarditis. Does this patient have myocarditis? I think that's still a question. And the answer is maybe. If we look at the most recent guidelines, this patient would have stage D myocarditis. And in order to have stage D myocarditis, you have to fulfill the criteria for stage C myocarditis and have hemodynamic instability. And so we can see how we diagnose it is you have classic symptoms of acute myocarditis, and you either have histopathology or CMR evidence of myocarditis, or you could have elevated troponin with additional supportive evidence. So I think that's pretty subjective and left to interpretation. So this patient, her EF recovered with supportive care during her hospitalization. She was discharged on some GDMT, and she's doing well with minimal symptoms. She also is undergoing genetic testing just because of the high association of genetic abnormalities with myocarditis. So to summarize, dengue virus primarily causes febrile illness. Myocardial injury is common, and cases of myocarditis have been reported. No specific antiviral treatment for dengue, and management is supportive. And there is a vaccine, but it's only for children 9 to 16 years old in the US. And I think maybe we just have a minute if anyone has questions or comments. Great, we'll go on to the next case. All right, so our next patient case is a case of aortic dilation. So we have a 48-year-old woman. She has a past medical history of bilateral breast cancer and is currently receiving chemotherapy, who presents with 2 days of pleuritic chest pain, fevers, cough, and shortness of breath. On discussing with her further, it seems like she's having episodes of these have occurred over maybe the past year or so, but it became so severe that she decided to present to the emergency department on this day. She received neoadjuvant chemotherapy with pembrolizumab and paclitaxel, and her current chemotherapy is with doxorubicin and cyclophosphamide. She recently underwent bilateral mastectomy after completing her neoadjuvant chemotherapy course. That was about a month ago. She also has hypertension. She's on lisinopril. Her family history is non-contributory, and her social history, she just has social alcohol use. So at the outside hospital, her vital signs were pretty unremarkable, and her exam was honestly unremarkable as well from a cardiovascular standpoint. Her labs are notable for anemia, which was fairly stable over the course of her receiving chemotherapy. Her BNP was normal. She had a little bit of a troponin elevation, and then she had pretty significant elevated inflammatory markers with her CRP being 23 and ESR of 130. An EKG was done, which I think has some ST depressions in V4 through V6, otherwise a pretty normal EKG. Next, a CT scan was performed, which we can see the results here. This was obtained to evaluate for a pulmonary embolism. She did not have a pulmonary embolism, but as you can see, she does have a dilated aorta. Her maximum ascending aortic diameter is 5 centimeters, and this was increased from 4 centimeters on a CT that was done just a year ago. She also had marked wall thickening and inflammatory changes surrounding the thoracic aorta from the mid-ascending aorta through the mid-descending aorta and subclavian artery. She also had severe focal stenosis of the left subclavian artery. An echocardiogram was obtained, mainly just notable for a large aorta. She had normal biventricular size and function. She had no significant wall motion abnormalities, and then she had mild to moderate aortic regurgitation. As we can see, she is just noted to have severe dilation of the ascending aorta measuring 5.3 centimeters. So in summary, we have a 48-year-old woman who has a past medical history of breast cancer, who's currently receiving chemotherapy and presents with 2 days of pleuritic chest pain, fevers, and shortness of breath, found to have new inflammatory changes of the thoracic aorta with an ascending aortic dilation from 4 centimeters last year to 5 centimeters. And so during her hospitalization, vascular surgery is consulted, and she does get blood cultures and syphilis testing, which both return negative. And so for our next poll, I want to know what you guys think is the next best step in management for her aortic dilation. So should we go ahead and do surgery now? Should we do some surveillance, endovascular repair, or should we start high-dose corticosteroids?
Numero uno.
Super excited about that,
They won't be. They won't be excited about it, but you know.
Yeah, so the concern is that she has aortitis. All right, well, we'll get to hear what the cause is. So I'm gonna go ahead and end the poll. And the results, so we had 19% state that we should go ahead and do surgery now with the ascending aorta and hemiarch replacement. 10% thought surveillance, 5% suggested endovascular repair, and 67% wanted to start high-dose corticosteroids. So she gets started on IV Solu-Medrol. She had an immediate improvement in her symptoms, which are mainly just the shortness of breath and chest pain. And then her doxorubicin and cyclophosphamide adjuvant chemotherapy was discontinued in favor of cyclophosphamide, methotrexate, and 5-fluorouracil for 6 months. The cyclophosphamide and methotrexate were thought to both treat her breast cancer and treat the presumed aortitis. She gets referred to CT surgery and to cardiology, and CT surgery was not excited about doing a surgery at this time, but wanted to do an ascending aorta and hemiarch replacement once there was no longer active aortitis. So she undergoes surveillance PET imaging after this treatment above, and unfortunately she has continued evidence of aortitis. So she gets treated with pulse dose steroids and tocilizumab for 4 weeks. She has another PET CT that shows continued evidence, so she gets another dose of tocilizumab, and then this happens again, and so she gets another 6 weeks of cyclophosphamide. Then she develops exertional angina. So she undergoes a coronary angiogram, which is notable for these findings. She has no obstructive RCA disease, but we can see that she has moderate diffuse disease of the left main, and this was IFR positive at 0.77. She had an angiographically normal LAD, and then it was thought that this vessel represented a ramus intermedius here, and it was thought to just have 20% proximal stenosis. Her circumflex was described as small and with no obstructive lesions. An MRA is also performed, again, to look for evidence of inflammation and to measure her aortic dimensions. Now it's been a little over 8 months since that CT scan where we showed that 5-centimeter aorta. Her aorta measure is 5.6 centimeters. She has continued evidence of active vasculitis on her MRA. And so I wanted to ask with our third poll, what is the next step management for her aortic dilation and left main disease?
No, I'm doing quattro this time. I'm doing number 4.
So we'll go ahead and turn on that poll. So should we do ascending aorta and hemiarch replacement? Should we do surveillance, left main stenting? Should we just restart her high-dose corticosteroids? We have her in the cath lab. Might as well stent, right? All right. So I'll go ahead and show the poll results. So we have 33% of people saying that she should undergo surgery, get an ascending aorta and hemiarch replacement. No one wants to do surveillance. 17% want to do some left main stenting, and 50% suggest that we just restart her high-dose corticosteroids. So what happened at this time is, due to her rapid aneurysmal growth of the aorta, the decision was made to pursue ascending aorta and hemiarch replacement plus CABG. Her lima was unfortunately not present anymore. It got occluded because of the involvement of the left subclavian artery with her vasculitis. So they did a free REMA to LAD. And we have some pathology results from her surgery.
Thank you, Shauna. So here's a low power view of the aorta, and it's markedly abnormal. So you can see that there's 3 layers. If you look towards the left, that's the intima. It's markedly expanded. Normally that should just be a thin layer laying on top of the black staining media. Here it shows massive fibromuscular hyperplasia and a lot of myxoid change. Then if you look at the central layer, which is the media, that's supposed to be a bunch of lamina of elastic fibers. And it has this moth-eaten appearance. So you can see that it's broken, fragmented, replaced by other types of cells, as well as some pink staining tissue. And then the adventitial portion, so the lower right, that's very fibrotic. So normally that is sort of loose fibrous connective tissue, but it's very fibrotic. If we hone in then on the media, we can see this area of medial necrosis. So that normal area of media is supposed to have elastic fibers and viable smooth muscle cells. You can see everything is dead. And then it's completely surrounded by this granulomatous inflammation. And you can see these palisading histiocytes that are circling around this area of necrotic media. And there's even on the lower right, there's a giant cell present. So this is a granulomatous aortitis with giant cells. We can go to the next slide. Here's higher power view. Again, you can see this island of necrotic media surrounded by granulomas. You can see areas of necrotic media, higher power view of the intimal fibrosis, and then the giant cells present and adventitial fibrosis. You can go to the next slide. Okay, just here we show those areas. And then higher power view, again, showing this granulomatous inflammation around an area of necrotic media with giant cells present in this histiocyte-rich granuloma. And again, granulomatous aortitis. Next slide. Then just some higher power view of some of the giant cells that are present here. And there was some, I think, question about whether this might be some IgG4 related disease as well. And there were a few plasma cells present, but they were just a minor population, and there was not pathologic evidence of an IgG4 related disease. So in the end, this patient has this granulomatous aortitis with massive destruction of the aortic wall. It's really histologic findings that we can see in giant cell arteritis or Takayasu arteritis amongst a number of other types of diseases. And ultimately, the etiology of this is then ultimately defined by the clinical scenario, determining what's really causing this type of disease. Thanks.
Thank you, Dr. Smith. So she was diagnosed with immune checkpoint inhibitor aortitis. This is because she had prior treatment with pembrolizumab. She was on that when her symptoms actually started. If you spoke to her, she described the shortness of breath and chest discomfort while on pembrolizumab, but didn't worsen until she presented. And so I wanted to talk just a little bit about immune checkpoint inhibitors. They're becoming more common and used to treat a lot of malignancies. There's a large amount of immune checkpoint inhibitors available for treatment of malignancies. The most common I'm familiar with is pembrolizumab and nivolumab. And so what these drugs do is they help actually activate the immune system. So normally we have receptors on our cells that these drugs can bind to that tell the immune system that we're a native cell and please don't activate the immune system against me. And so what these drugs do is they inhibit those receptors, and therefore you increase immune system activation, and that can lead to a whole host of complications and toxicities. And so the most common cardiovascular manifestations of immune checkpoint inhibitors are going to be myocarditis, pericarditis, Takotsubo, and then arrhythmias. You can also develop vascular toxicities. Vasculitis has a prevalence of 0.2% in these patients. And then myocarditis is probably the highest prevalence. These can be in about 6.6% of patients. You can have myotoxicities. This was just a study that was done from Immunocancer International Registry. And so this only shows patients that have biopsy-proven vasculitis and was thought to be related to immune checkpoint inhibitor use. And we can see here, there's not a lot of cases, but in all the patients who had aortitis, they had histologic findings that were consistent with giant cell arteritis, just like in our patient case. So what do we do about these immune-related adverse events? The guidelines at this time, if you have suspicion of immune-related adverse events, which is the complications from these medications, then you should first evaluate for alternative causes. And then if it's thought to be related to the immune checkpoint inhibitor, you're supposed to grade the immune-related adverse event. For each different type of adverse event, at least the more common ones, like thyroid toxicity, there's a specific grading scale for each specific type. There's not one for vasculitis. And so grade 1 would be any patient with asymptomatic or mild symptoms. Grade 2 is moderate symptoms. Grade 3 is severe, and grade 4 is life-threatening. And in grade 3 or 4 toxicities, what you're supposed to do is withhold or permanently discontinue the immune checkpoint inhibitor. She's already off hers, and then initiate corticosteroids for treatment. If they have refractory symptoms, you're supposed to consider immunosuppression, as was done in this case. And there's a variety of different immunosuppression regimens. These are mainly driven by rheumatology for treatment of vasculitis. So what do we do about surgical management, and why did we wait so long to do surgery in her? And the reason is surgical management is ideally deferred until the aortitis is no longer active. This is supported by both rheumatology guidelines and our ACC-AHA guidelines, our guideline for management of aortic disease document. And it's recommended that the surgeries be achieved after stable remission. The surgeries be done after stable remission has been achieved. And it's because vasculitis is associated with an increased risk of operative and postoperative vascular complications and reoperation. So this was a study that just looked at patients who had a thoracic aortic aneurysm and either aortitis and no aortitis. And the reoperation rate in patients with aortitis was twice that of the non-aortitis patients. So 17.5% versus 9% in this patient population. And this was mainly driven by the risk of aneurysm formation postoperatively. There was another study. This was a different patient population. They all had Takayasu arteritis, but this is the article that's most frequently cited in the guidelines. This was 79 patients with Takayasu arteritis, and they found that the 5-year arterial complication rate was 44%. And so we can see even at 6 years, there's a 50% risk of arterial complications. And so these include bleeding, stroke, or a need for reintervention on these patients. In that the patients who had biological inflammation at the time of revascularization increased the risk by 7 times the likelihood of complication. And this did not matter if the surgery was open or endovascular. So in summary, this patient had continued elevation of inflammatory markers even after she underwent surgery. And so she's still on infliximab, Q6 weeks, methotrexate, and prednisone. She's been on immunosuppression for almost 4 years now. She had a CTA chest that was done postoperatively with just expected postoperative changes. And she's actually asymptomatic. So take-home points for ICI aortitis. It can cause a range of cardiovascular toxicities, including myocarditis, arrhythmias, and vascular complications, such as aortitis. ICI-induced aortitis is rare, with limited case reports describing histologic features similar to giant cell arteritis. And delaying surgery in patients with vasculitis until remission is achieved is preferred due to the risk of intraoperative and postoperative complications. Any questions or comments?
Well, obviously, this is sort of an extreme case, but did you come in your look at the literature, did you come across any evidence that someone who has, let's say, a 4-centimeter aorta, who had aortitis, who got all this immunosuppression, actually it resolved? In other words, it didn't get larger? I mean, is that a possibility, I guess?
Yeah, so it didn't, I don't know if I have cases that document like if there was still dilation after like treatment of the aortitis or vasculitis, but there in patients who developed immune checkpoint inhibitor vasculitis, 80% respond to just prednisone therapy alone is what I'd found. But I don't know about the long-term complications. That's a great question. Anything else? It was actually before she had gotten the Pembro. She was on Pembro for very long. So that was when she was diagnosed with her malignancy. She had an aorta size of 4.
I wonder if her aortic tissue was not level to begin with.
Yeah, that's a fair point. No one had investigated her aortic tissue more, but yes. Okay.
If you want to go ahead and, if you want to go ahead and talk.
Hello, can you hear me? Hello, can you hear me?
Yes.
Yes, we can hear you.
Just question is, it seems unclear to me what a level of stabilization or, you know, a time when you have sort of non-aggressive activity going on in the tissue. And it didn't seem to me that there was ever an evidence that there was really good stabilization of the disease before the surgery was taking place. I'll take your comment.
Yeah, Dr. Probstfield, that's absolutely correct. In this specific patient case, she had no evidence of remission. The reason that they decided to pursue surgery was just because of the rapid expansion of her aorta, and because at this time it's now 5.6 centimeters. So it had grown, 1.6 centimeters over the course of like an 18-month period. And so at that point, they just decided to pursue surgery, given the risk of dissection was thought to be very high.
I'm just struck by 4 years of immunosuppression with no remission. And is there a point where we say the cost and risk of continued immunosuppression versus no clinical response should make us either stop or pursue some other avenue? That seems pretty remarkable.
Yeah, that's a great question that I'm not sure I know the answer to. She's followed closely by rheumatology, and they've tried like multiple different types of immunosuppression regimens. But at this time, she's asymptomatic and just with mildly persistent elevated inflammatory markers. So it might be reasonable to try and stop it. Yeah, so that's actually common. What was asked was even though the ICI was discontinued, you can still have these complications. And yes, even like ICI myocarditis, we can see it up to 2 years after discontinuation of the medication.
But like this is 4 years. It doesn't. I guess it's beyond. I don't know much about this area. It just seems like I feel like it seems like there's something else going on.
Yes. It seems like she must have some sort of.
Yeah, the rheumatologists are super smart. So I'm sure they investigated other things.
Thank you all for your comments. We'll move on to our last case, which is a case of diffuse vasculopathy. So we have a 61-year-old man with a past medical history of mitral valve prolapse and paroxysmal AFib who presents to establish care after a recent hospitalization. So I'm going to put you all in the shoes of this cardiologist that's seeing them for outpatient management. He was recently admitted with acute decompensated heart failure and sepsis. He was found to have mitral valve endocarditis. He had pretty large vegetations. One was 1.4 by 3.3 centimeters, and the other was 0.6 centimeters. And so he ultimately gets a mechanical MVR. Unfortunately, before his mechanical MVR was done, he develops bilateral septic embolic popliteal occlusions, which seems like a horrible complication. The vascular surgery team, given his acute endocarditis, they initially just tried some conservative management and initiation of anticoagulation, but he had pretty persistent left lower extremity rest pain. And so he actually required above the knee popliteal to anterior tibial artery bypass. And then when he underwent the CT scan to evaluate his bilateral septic embolic popliteal occlusions, he was found to have all these abnormalities, multiple different aneurysms. So he has an aneurysm in his iliac artery, his celiac artery, his common hepatic artery, his splenic artery, and then his inferior mesenteric artery had multiple irregularities. He also had ectasia of his left common iliac artery. He had no associated atherosclerosis with any of these lesions, and there was no evidence of mycotic aneurysms in any of these areas. So when you see him, he's currently feeling well. He has no complaints. You are very astute and go through a thorough review of systems, and he notes no ophthalmologic issues, no increased flexibility, easy bruising, bleeding, poor wound healing, or flat feet. His family history is honestly pretty unremarkable. His father had an MI age 87, and there's no family history of sudden cardiac death, aneurysm, or dissection. Social history, he has no tobacco or drug use, rare alcohol use. Physical exam is unremarkable as well. His blood pressure is 128/74. His cardiac exam, you just hear the mechanical valve clicks. Everything sounds pretty normal. And then you note that he has no scoliosis, no pectus excavatum, he has no joint hypermobility, and he has no craniofacial abnormalities. His meds, fairly standard. He's on aspirin and atorvastatin. Those were started because he had the bypass procedure. He's on metoprolol succinate 50 milligrams BID for his paroxysmal atrial fibrillation, and then he's on warfarin therapy for his mechanical valve. You get some labs, things look good. Normal CBC, CMP, LDL is 59, and his INR is at goal. So in summary, you have a 61-year-old man who has a history of mitral valve prolapse, paroxysmal atrial fibrillation with recent mechanical MVR, and popliteal to anterior tibial bypass for treatment of endocarditis and complications. He has all of these aneurysmal dilations, but he has normal labs. He's asymptomatic. He's unremarkable physical exam, family history, and social history, and he is already followed by vascular surgery, though they haven't commented on any of these aneurysms. So for our last poll, what is the next best step in management of this patient? So we'll go ahead and pull up in that poll. Oh, okay.
Say phone a friend and have a conversation with your vascular surgical colleagues.
Phone a friend, okay. Jennifer, I don't know if you can see the results of the poll there, if you want to stop the poll. Great. So I can see the results now. So first, it looks like 20% favor just repeat CT imaging, 20% wanted to send vasculitis lab testing, 40% wanted to start an ARB and really reduce that blood pressure to less than 120/80, and 20% want to send genetic testing. I don't know if there's a right answer for this one. but we'll go through the patient case. So his cardiologist had done no further testing, and unfortunately, he gets lost to follow-up for 4 years. He eventually comes back, presents to the emergency department. He has chest and abdominal pain. Interestingly, he's found to have a SCAD of his RCA. This was a very distal aspect of his RCA. It's treated conservatively. And he did have a CTA chest, abdomen, and pelvis at that time, but it was noted to have poor contrast timing and just said the proximal vessels are patent. He gets discharged and then represents to the emergency department with persistent abdominal pain. And these findings. So there's a lot of findings over here on the CT. I'm just going to try and summarize. And it goes kind of fast, but he has bleeding in his spleen. He has aneurysmal dilation of his celiac artery, thickening and irregularity of his left gastric artery. He has a dissection of his common hepatic artery. He has an aneurysm of his gastroduodenal artery and a variant aneurysm arising from the gastroduodenal artery. He also has dilation of multiple other vessels, and then another dissection of his inferior mesenteric artery. He has right renal artery irregularity, and then he has the dilations of his left common iliac artery and right common iliac artery. He unfortunately is in hemorrhagic shock at this time. He gets admitted to the MICU, and vascular surgery and IR were consulted, and actually no procedural interventions were offered. It was thought, given his diffuse vasculopathy, that his tissues would be too prone to injury and that open operation would be fatal. So they did send genetic testing during his hospitalization. And unfortunately, he just developed progressive hemorrhagic shock with multi-organ failure and expired during that admission. And so an autopsy was performed.
Thank you. So it was the immediate cause of death, I think is pretty obvious. He had hemorrhagic shock, and his peritoneal cavity had about 3 liters of blood. There was a rupture in the capsule of the spleen, so that bleeding that was seen in the spleen was probably due to a ruptured aneurysm that eventually led to rupture of the spleen and then just a catastrophic bleed. There was also infarcts and ischemic injury in nearly all of the abdominal organs, but obviously what we're interested in is what's going on in the patient's arterial system here. And I'll just show you a few of the arteries. Just we essentially saw what was reported by CT, that there were dissections and pseudoaneurysms in the distal right coronary, common hepatic, gastroduodenal, gastroepiploic, splenic, renal, superior mesenteric, and inferior mesenteric arteries. There was also aneurysmal dilation of the aortic root and the common iliacs. Here's a picture of the superior mesenteric artery with a dissection and a pseudoaneurysm. You can see the left is just an H&E stain, and then the right is a VVG stain. And the VVG stain, you can make it out a little bit better. There's just this crumpled up version of the original intimal portion and lumen of that vessel with a little bit of the internal media associated with it that's, I think, completely obliterated at this point. And then there's the pseudoaneurysm, that essentially the false lumen that's essentially filled with blood and engulfing that and squishing down on that small residual portion of the vessel. Go to the next slide. Okay, so here is an example of the splenic artery that is still functioning but does have a dissection. You can see that a portion of the wall, we see a dissection with a false lumen with some blood in it. And then you can also get an appreciation for the fact that this has been ongoing for quite a while. Since we have all this on the right panel, you can see in the blue on the adventitial aspect is the adventitial fibrosis. So there's very prominent adventitial fibrosis. So this has been a chronic problem that's evolved over time in this individual. And then the next. So this is one of the gastroduodenal artery, and this one had no dissection or aneurysm, but it just shows some interesting changes in the media. So the lumen, it has blood in it, and then we see a thickened intimal layer that's hyperplastic. Then we see this internal medial layer that the arrow is pointing to. It's just a layer of smooth muscle. And then there's this region here where we've lost the smooth muscle cells that we're terming medial lysis. And there's, we'll look at that at higher power. And then there's a small band of the external portion of the media. And then a lot of adventitial fibrosis there. And so there's something that's happened, this very mysterious injury that's really targeting sort of this external portion of the medial layer, the smooth muscle layer that's present in it seems like almost all of the patient's arteries. Next slide. And so here's a higher magnification view of what I just showed you, where we see this area that's in the external portion of the media. And here it looks sort of like granulation tissue, and that we see these small vessels. We see there's smooth muscle cells have been replaced by neovascularization, small vessels. There's a lot of lipofuscin-laden macrophages there. So there you get the impression, I get the impression that there's been some injury to this layer and then a reparative process. And what causes that injury, why it's so diffuse, and I think is a mystery that I have no idea about, and I don't know if anyone really does. I'm presuming then again that this leads to weakening of the arterial vessels that then makes the patient susceptible to the dissections and the pseudoaneurysms that we've seen. I think that's it.
Thank you, Dr. Smith. So this patient's final diagnosis is segmental arterial medial lysis. This was a diagnosis that I'd actually never heard of until about a month ago. I had a clinic patient that had the same disorder, and I asked the echo lab if they had ever heard of this, and we found another patient case. And so you might have similar questions that I had a few weeks ago, what it's abbreviated as SAM. What is SAM? How is it diagnosed? And then how do we treat this? And so SAM is a non-inflammatory medium vessel vasculopathy. It's most common in men ages 50 to 70. And abdominal pain is the most common presenting symptom. Unfortunately, this is because most of the presentations are due to vessel hemorrhage or dissection. It's characterized by medial lysis in a patchy pattern, as was described by Dr. Smith. So what is thought to happen is you get acute lysis of the smooth muscle in the vascular wall, and this leads to the formation of vacuoles in the medial layer. And eventually you get arterial gaps in the damaged internal elastic lamina and intimal layer. And so this makes the blood vessels prone to dissection and or aneurysm formation. And this is later followed by a reparative phase with granulation and fibrosis resting in the injured wall. And so these patients, after the reparative phase, they can still have stenosis, they can have aneurysms, or they can have arterial wall irregularities as described in our patient. Interesting enough, in most patients, it takes kind of a relapsing remitting course. So you can have periods of time where you have no evidence of disease, and then you can develop these SAM lesions, and then they can resolve on their own, but some of them have these arterial complications. The mechanism is not known. It's postulated by some groups. It's thought that maybe the patchy appearance is because of where sympathetic nerve endings end on the vascular system. It's kind of in patchy, diffuse areas. And it's thought that maybe a local temporary increase in norepinephrine secretion causes this like exaggerated vessel response, and that leads to local smooth muscle injury. This is supported just by like anecdotal reports, and that SAM lesions have been described in patients who are getting alpha or beta receptor agonist And it's been described in animals who are getting beta-2 agonists, which is used for growth promotion in livestock breeding. It's also been seen in patients with pheochromocytoma. So thought maybe to do with the sympathetic nervous system, but we don't know. It typically involves the mesenteric vessels. I think that's one of the defining features. And so in 61% of patients, there's involvement of the celiac artery. It can include the renal arteries, cerebral vascular arteries, and rarely include the coronary arteries. How do we diagnose it? Diagnosis is based predominantly on radiologic imaging findings that are consistent with SAM. This was a proposed scoring system for the diagnosis of SAM. This is by a group in the Netherlands. And this scoring system was just developed by a multidisciplinary expert team. It's kind of hard to test it against any sort of gold standard, as this is like a very rare disease. And so this is just expert consensus. But we can see here, like for our patient, he initially just had arterial abnormalities, and you're looking for a specific arterial abnormalities of dissection, hematoma, aneurysm, or a patchy beaded appearance. You're looking in specific arteries, usually the celiac, mesenteric, renal, iliac, or cervical arteries, or their side branches. And so our patient initially would just have a score of 2, which is possible SAM. And then after you develop symptomatic celiac or mesenteric artery bleeding or dissection, like we had in our patient, that increases your risk to probable SAM. This is what we would give my clinic patient that I saw about a month ago. And then really the most, there's this histopathological evidence for SAM that is rarely acquired unless it's on autopsy, just because biopsying some of the mesenteric vessels is usually not pursued. Here's kind of how I think about the differential diagnosis. I made this chart. And so when you're thinking of patients that have diffuse vascular conditions, there's a few things that you want to evaluate for. One, is there any evidence of inflammation? And if there is inflammation, then that kind of brings you down a pathway of evaluating for vasculitis or infectious vasculopathy. If there's no inflammation, I think the next step is really to send genetic testing. So what you're looking for are diseases like Marfan's, Loewy Dietz, and vascular Ehlers-Danlos, which can all have like diffuse blood vessel pathology. If genetic testing is negative, that's when you're going to put your patients into the segmental arteriomedial lysis, fibromuscular dysplasia, or atherosclerosis bucket. Remember, in SAM patients, it's usually 50 men ages 50 to 70, so atherosclerosis is common. I think the most challenging diagnosis to differentiate SAM from is fibromuscular dysplasia. My clinic patient is a woman in her 50s who also had a SCAD episode. And so it's hard to differentiate these two because they have very similar radiologic findings on like CT imaging. How you could differentiate these two would be to get a biopsy, again, of a blood vessel, but that's generally not pursued. How do we manage these patients? There's no specific treatments. Management is targeted at cardiovascular risk reduction. Intervals to CT surveillance imaging is recommended by most. And there was one, it had 26 patients at their institution where they monitored by CT imaging at 1 month after diagnosis, 6 months after diagnosis, and then a year. And what they found is that 25% of their patients had complete resolution in all of their SAM lesions, 25% developed new lesions, and the remainder had very stable findings. In my chart or my literature review, I didn't see a signal that intervention is associated with an increased risk of complication as like we saw in the vasculitis patients. But again, there's only a limited number of patients. And so it seems like intervention is performed usually just by standard interventional like guidelines. It's usually embolization of an aneurysm or stenting of a dissection or stenosis. And so the take-home points: segmental arteriomedial lysis is a rare non-inflammatory vasculopathy that typically affects middle-aged males. It involves the medium-sized arteries leading to dissections, aneurysms, or stenoses. Diagnosis is predominantly based on characteristic imaging findings. I would recommend evaluating for vasculitis and connective tissue disorders in appropriate clinical situations. Any questions or comments? Great. Well, thank you so much to these 5 who either helped me find these patient cases or taught me a little about these different types of diseases. Thank you.